Today we have the pleasure of hearing from Dr. Michelle Kim, the Vice Chair for Faculty Affairs for the Department of Medicine at the Icahn School of Medicine at Mount Sinai, as well as Professor of Medicine and Co-Director of the Center for Carcinoid and Neuroendocrine Tumors. Dr. Kim earned her undergraduate degree from Harvard College and her medical degree from Stanford University School of Medicine. She completed her postgraduate training in internal medicine and gastroenterology at New York Presbyterian Hospital, Cornell. She has lectured nationally and internationally on carcinoid and neuroendocrine tumors and is known for her work in translational and epidemiologic approaches in assessing outcomes in patients with carcinoid NETs. Dr. Kim is currently chair of the Carcinoid and Neuroendocrine Tumors section of the American Gastroenterological Association and was the president of the New York Society for Gastrointestinal Endoscopy, largest regional endoscopic society in the United States. She has received research funding from the American Cancer Society, the Mount Sinai CTSA, and the Carcinoid Cancer Foundation. Dr. Kim has published more than 50 articles in journals such as the Journal of Clinical Oncology and Gastroenterology. Please join me in welcoming Dr. Kim.
Thanks very much for that kind introduction. It's such a pleasure to see so many familiar faces out there. These are sort of I'm preaching to the choir, I can see, for neuroendocrine tumors. I'm not sure if many of you know that we really have a very special history and experience with carcinoid and neuroendocrine tumors, so I'm very happy to be able to share some of this with you today. So we'll start off with just perhaps a brief recap of this very interesting and long history at Mount Sinai. Because it is a rare disease, I would like to just give a little bit of background just so that we make sure we're all on the same page. We'll give a little bit of an update of what's new in neuroendocrine tumors, and then finally just wrap up with some of the studies that we're doing here at Mount Sinai. So I think the first question is, we always have to ask why carcinoid. It's certainly a very rare disease. This is not something that anyone ever really dreams of specializing in when they're in medical school. But it is a rare disease, but it's just with increasing incidence. I'll show you in just a minute how the incidence has increased over 7-fold over the last few decades. In addition, it's a fascinating disease. It's one with a wide spectrum of biologic behavior. Because of that, it's challenging to treat. And so understanding which patients belong in sort of a more stable disease group and those that progress much more quickly, I think is one of our challenges in this field. Survivorship is something that we're dealing with more often. We now have patients who are living for many years, and so it's not just a matter of controlling the tumor, which is one aspect, but it's also how do you counsel your patients when they often have to live with this disease for many years. As I'll go into in just a minute, it has significant morbidity and mortality. I know that I'm a gastroenterologist, but we certainly interact all the time with our oncology colleagues. And so in terms of tumor control, that's one way in which we collaborate. But other collaborators are also important. I've certainly seen many patients with doctors in this room, from Jerry Zaks from cardiology to Emily Gallagher from endocrinology. And so we have many different collaborators and consultants that we often work with in caring for patients with this disease because it often does affect many systems. It's a fantastic opportunity. There are not that many centers in the U.S. There are more neuroendocrine tumor centers in Europe. There's really a growing interest in Asia. And so I think it's really for any budding a physician who's looking for a very narrow and well-defined niche, this is actually not a bad one. And then finally, as I said, we do have a very unique experience here at Mount Sinai. You can't really talk about carcinoid and neuroendocrine tumors without talking about Dick Warner. So how many people recognize this picture here? Yeah, so Dick Warner is really synonymous with carcinoid and neuroendocrine tumors at Mount Sinai. He has had over 60 years of experience with carcinoid and neuroendocrine tumors, and was really the first person to show me that you could actually subspecialize in something this rare and actually make a career of it. His entire practice for years was dedicated to the care of these patients, and so over his 60-year-plus career, he really cared for thousands of patients. So with your permission, I'd just like to recap perhaps some of the last 60 or 70 years or so of carcinoid and neuroendocrine tumors. So the first was in the 50s when actually Thorson et al. Described carcinoid syndrome in the New England Journal, and this was the classic flushing, diarrhea, wheezing, palpitation story of carcinoid syndrome. And then a year after that, Dick Warner, who actually, for those trainees in the room, was the first GI fellow of Henry Janowitz, described bronchial carcinoid causing carcinoid syndrome. And this was actually a very interesting case. While he was actually in the Air Force, he had seen a case of carcinoid syndrome with a midgut neuroendocrine tumor. And this was years later after his service when he actually was reading up about diarrhea, had a patient with diarrhea, and realized that there was actually no history of a midgut or small bowel neuroendocrine tumor. And so, but the patient actually did have a history of lung cancer. And so he dug up those dusty slides from several years prior, dug them up out of the archives, and actually found that this was a bronchial carcinoid, not a lung adenocarcinoma. And so his experience back then where it was misdiagnosed is actually something that we sometimes see up till this day. We then saw that many of these patients would have metastatic disease to the liver, and so we found that we could perform radioembolization. This was really a precursor to what we now do for a lot of cancers where they have metastatic disease. In the 80s, the FDA approved octreotide, which is a somatostatin analog, for the treatment of carcinoid syndrome. And this is something that was really the only agent for carcinoid syndrome until several decades later. And so this was really the stalwart of our treatment and the basis for how we treated carcinoid tumors. We then had a case series of a few dozen cases of chemoembolization. In 2008, Dick Warner, I don't know how many of you remember that he was actually on the voluntary staff for many years and then joined the full-time faculty recruited by Lloyd Mayer, who was the GI chief at that time. And at that time, we joined forces and became the Center for Neuroendocrine Carcinoid Tumors and continued to see a very high volume of these patients. In 2017, peptide radioreceptor therapy became available here at Mount Sinai. And then most recently, we've managed to recruit Edward Wolin, who is now the director of the Center for Carcinoid and Neuroendocrine Tumors. And together, our center with Dr. Wolin, as well as with many of our other physicians, see probably what is one of the largest volumes of neuroendocrine tumors in the United States. We have over 200 new patient visits per year. And so this is a very high volume center for something that is quite rare, and it's really quite a privilege to be here. Just to bring you up to sort of the immediate time, in terms of neuroendocrine tumors at Mount Sinai, just in recent weeks, we've actually had 3 patients hospitalized. And so there was a patient actually who was in the medical ICU who had carcinoid crisis. And this was something that we don't see that often, but it can be life-threatening. He had hemodynamic changes, and was really in shock. Also had a very profound flushing and diarrhea. We had patients who were admitted for severe diarrhea and weight loss, and then also patients who were admitted for abdominal pain who were found to be have anasarca, and then ultimately were transferred to palliative care and then ultimately passed in the hospital. And so really there's quite a high probability, for a rare disease that, especially if you're at Sinai, that you will at some point intersect with a neuroendocrine tumor. So just to make sure we're all on the same page, just want to define a neuroendocrine tumor. The origin of the carcinoid and neuroendocrine tumor is the enterochromaffin cell. It's widely distributed throughout the body, especially prevalent in the submucosa of the GI tract and the bronchi. And I think part of what makes it so memorable is that you really get a variety of biogenic amines and peptide hormones. And so this can often lead to overproduction of certain hormones that you see here, serotonin being the most notable of them, and often associated with the carcinoid syndrome, as I said, that very dramatic flushing and diarrhea. We also do see other neuroendocrine tumors that can overproduce other substances such as gastrin and insulinoma and VIP. So for instance, for VIP, you'll often get a very cholera-like picture, and these patients can come in with severe electrolyte disturbances that are very troublesome to treat. One question I get asked a lot is what is the difference between a neuroendocrine tumor and a carcinoid? So I thought that I'd just sort of lay that to rest. And part of it is just that it's really a nomenclature question. In this day and age, we're trying to go a little bit more towards actually calling patients, these patients with neuroendocrine tumors. But I will say that where it really seems to persist in terms of using the term carcinoid is when you're talking about carcinoid syndrome, carcinoid heart disease, carcinoid crisis, and this is generally associated with the overproduction of serotonin. But as you can see here, you can have neuroendocrine tumors from a lot of different places, the stomach, the small bowel, rectum, and pancreas. I haven't included the most common one, which is also those of the lung, but as I said, I'm a gastroenterologist, and so I tend not to see quite as many of those. Okay, so perhaps we can start off with a few misconceptions. I'd love to make sure that everyone walks out of here an expert, since this is something that we see so much of. So the first is that neuroendocrine tumors are a homogeneous group with similar biologic behavior. I'd love to really disabuse everyone of this notion. So in fact, neuroendocrine tumors are a very heterogeneous group, and you can range from having patients who have very stable disease and are doing quite well and have decades of survival, to patients who have very aggressive disease are treated with cytotoxic chemotherapy. And so understanding which one you're dealing with, I think, is of really critical importance. Again, that they're benign and indolent. Some neuroendocrine tumors are benign, this is true, but many of them are malignant. Some of them may be malignant and indolent, which is a little bit perhaps difficult to wrap your mind around. One way that it was taught to me early on was that it's a cancer in slow motion, and so you can have widely metastatic disease, but it can still be a very slow-growing tumor. That patients don't die from neuroendocrine tumors. Again, we've had patients just recently in the hospital who have passed away from neuroendocrine tumors, so this can certainly be a fatal disease. That there's no effective treatment. I hope to review for you that there are many effective treatments, and again, what makes part of this field so very rewarding is that we collaborate with so many terrific experts across all departments. So in terms of, from the perspective of a gastroenterologist, again, these tumors are uncommon but increasingly prevalent. Because patients survive for such a long period of time, we actually find that the prevalence is actually higher than the prevalence of esophagus, pancreas, and gastric cancers combined. And so actually this is a relatively common disease, and of these, you're often going to see disease from the small intestine. Just here is a little graph of incidence by site, and you can see here that the lung neuroendocrine tumors are those that are here in this curve that has been steadily rising. You can see here some of the GI ones. The black ones are the rectal neuroendocrine tumors. The rather greenish, stoolish color curve here is that from the small bowel. And so these are really what we see quite a few of, and especially those small bowel neuroendocrine tumors can be very troublesome to manage. We see here also a spike in the gray curve, which is the pancreatic neuroendocrine tumors, and this is something that we're definitely seeing much more of. And so, it remains to be seen whether this is really reflecting a true increase in incidence, or if this is something that perhaps just is related to detection bias. There's no question that we're doing a lot more cross-sectional imaging, CT and MRI. We're doing a lot more endoscopies and colonoscopies than before, and so perhaps this rise is not just that they're occurring more frequently, but that we're just detecting them more often. I wanted to share with you, in terms of making this diagnosis, it's always about zebras, right, not horses. And so for the patient support groups and for many of the net societies, the zebra is our mascot because when you hear hooves, you have to think not just horses, but also think zebras. And so you need to have this conglomeration here of different things. You have your clinical findings, you've got your biochemical biomarkers, you've got your imaging tests, and you've also got tissue acquisition. And I put tissue acquisition here in red because I will say that there are many patients who often will have symptoms of flushing and diarrhea and come to us because they want to make sure they don't have a neuroendocrine tumor. And it's been extraordinarily rare in those patients that we've actually found one. They often will have symptoms from some other entity. And so localizing tumor, having tissue is really critical. With flushing and diarrhea and with an elevated biomarker, that's just not likely to be the source, or a neuroendocrine tumor is not likely to be the source of the patient's problems. Okay, so in terms of clinical presentation, I want to focus a little bit more just on the small bowel, again, because it's got so many systemic manifestations. You're not supposed to play favorites, but as a parent, but as I think as a physician, the midgut neuroendocrine tumors are, I think, some of the most interesting neuroendocrine tumors there are. In terms of location, the most common primary site will be those from the ileum, the next most common from the duodenum, least common from the jejunum. And we're finding patients in all spectra. As I said, we are doing a lot more endoscopies and colonoscopies, and so we are finding a lot of these incidentally on screening colonoscopies. If your gastroenterologist happens to dip into the terminal ileum, go past the ileocecal valve, they often will find a neuroendocrine tumor that actually can be found at a very early stage, and so that's a way that we often are finding these incidentally. Now, when patients are symptomatic, we often will see extensive fibrosis from excess serotonin, and so this can lead to profound episodes of abdominal pain. Our surgical colleagues will often see obstructed patients. The GI service will often see GI bleeding and anemia. And many of our patients will actually present with abdominal pain and require surgery at some point in their clinical course. I want to point out here that we often have mistaken diagnoses as well. Irritable bowel syndrome, inflammatory bowel disease, especially here at Mount Sinai, are much, much more common than carcinoid and neuroendocrine tumors. But there are, every year, I would say a small number of patients who are diagnosed with these other more common entities that end up actually have a carcinoid and neuroendocrine tumor. Now, the syndrome, I have to say, disappointingly only occurs in a minority of patients. And so while it's the thing that we think about most frequently when we think about carcinoid tumors, it's really just not going to occur very frequently. And so when you do have carcinoid syndrome, what scenario will that occur in? Well, it's generally going to be associated with metastatic disease. It's usually going to be from the midgut, so you're not going to see these with, carcinoid tumors from the duodenum, from the rectum, from the pancreas. The most common will be those that have flushing, and diarrhea is also another very common manifestation. Our resident cardiologist, Dr. Zaks, knows that this will often result in carcinoid heart disease, primarily right-sided disease, and also will often be associated with wheezing. And so in terms of carcinoid syndrome, again, the manifestations are thought to be caused by serotonin. Normally, you would have the serotonin metabolized by the liver into 5-HIAA, which is then detected in the urine. But when you have carcinoid tumors or overproduction of serotonin, you then have an entering the systemic circulation. And so this will most often occur in the presence of liver metastases, and sometimes those also in the ovary. And so your syndrome will often depend on the volume of the disease. Quite frequently, when you have very high volume disease, your flushing will be much more difficult to control. And so I just want to review here some of the steps in terms of the synthesis and metabolism of serotonin. You've got here tryptophan that's catalyzed by tryptophan hydroxylase into 5-hydroxytryptophan, which is then catalyzed into serotonin. And you then have breakdown of the serotonin by these multiple steps into 5-HIAA. So in terms of the carcinoid flush, this will often be triggered by a variety of different scenarios. You can have alcohol, and specifically red wine, that often will be associated with this, spicy foods, certain cheeses, physical exertion, emotional changes, emotional stress can certainly be part of this. The differential diagnosis is broad, and again, many of these are much more likely to occur than to actually have carcinoid syndrome. Menopause is a very frequent other state that often can be confused with this. A clinical pearl for those of you who would like to buff up on your skills of differentiating menopause from carcinoids. Menopause is often associated with a sweaty flush. The women are often drenched and sweating. The carcinoid flush is often a dry flush, and so when you have patients who are not complaining of sweats with their flush, this is something that often will sometimes make us think of carcinoid. Okay, so just to show you what this can look like, on the left you can see a patient is very profoundly flushing here, and with really redness sort of going into the face and also going into the neck. And you can see here just a few minutes later the flush has resolved, and you can see there is a residual erythema here over the nose into the cheeks. Similarly, you can see here that the flush has extended all the way into the chest, and you can see actually this is the normal skin color here where the fingers are with the blanching of the fingerprints, and here you have a deep erythema that goes all the way down there, and so this is very typical of what we see. Abdominal fibrosis, I think, deserves a special word because so many of our patients do require surgery and often will have partial and complete small bowel obstructions. The other thing that ends up happening a lot of is that we have a lot of patients with retroperitoneal fibrosis, and so we rely on our urologic colleagues to often place stents for patients who have hydronephrosis. Many of our patients will then also go into renal failure. And so again, you're seeing many different systemic manifestations from this disease. For those who are cardiologists, we see that carcinoid heart disease is very common and usually will occur as right-sided fibrous plaques in the endocardium. The tricuspid valve, the pulmonic valve start to retract and become fixated. You'll often see tricuspid regurgitation, also stenosis across both the tricuspid and pulmonic valves. Doesn't usually occur on the left, and so this is primarily a right-sided disease. If it does occur on the left, it's usually because of the severity of the right-sided heart failure. The other thing also is that monoamine oxidase in the lung will degrade serotonin in the pulmonary circulation, and that's really why you're not seeing it so much on the left side. And then finally, I think just so that everyone's a little bit aware that such an entity exists, carcinoid crisis, again, something that we will see in our ICUs, sometimes that we will see around surgical and endoscopic procedures, potentially life-threatening. Patients start to flush. They start to have very profound hemodynamic changes. This can be associated with respiratory failure as well. Our surgical colleagues are already aware that this is an issue, and so they often will have patients prophylactically put on octreotide, not only subcutaneously, but also actually on an ongoing intravenous drip. And this often is thought to be caused by a surge of serotonin and bradykinin and histamine that occurs in the setting of this physiologic stress of having either a surgical procedure or some other type of stressor. And so we will give octreotide for prophylaxis and treatment of carcinoid crisis. This is one of the scariest things that we see, quite frankly. I've probably had to give octreotide maybe about 4 times in the endoscopic unit. And so we really try to be very careful. We try to make sure that we're keeping all of our patients safe so that we don't run into this issue. In terms of biochemical markers, I've already alluded a little bit to urinary 5-HIAA. It's got excellent specificity, very useful for our midgut patients, and lower 5-HIAA can often be associated with improved survival, and this is thought to be indicative of tumor volume and tumor burden. The cons here are that it's really got a suboptimal sensitivity. It's a 24-hour collection, so collecting your urine for 24 hours can be a little bit of a drag. It's not really great for foregut and hindgut lesions. It's really just going to be good for those people with midgut lesions. Not great for people with low volume disease. You get an awful lot of false positives with diet and malabsorption. And so you can see that we've got sort of a way to go in terms of developing biomarkers when 24-hour urine test is one of your best biomarkers. Just to let you know, for those of you, again, who are perhaps very clinically astute and you're thinking of your patients, this one might be having some flushing, let's check a 5-HIAA. Please be aware that there are a lot of foods and medications that can cause an elevated 5-HIAA. For those patients who come to see me with elevated markers without any evidence of disease, I would say that this is almost entirely the case, that they've had some sort of fruit, had some sort of nut, or some other lovely substance, wine, cheese, caffeine, and chocolate, that has led to their actual positive 5-HIAA. Another chemical marker that we use quite a bit is chromagen A. This is a glycoprotein that's stored in secretory granules in the neuroendocrine cells, co-secreted with biologically active amines, and again correlates with disease severity, tumor volume, burden, and prognosis. Same thing with this, that it's often associated with a lot of false positives. So we've got a lot of patients who have reflux and who are on proton pump inhibitors. And so again, for those patients who don't have carcinoids, please be very careful in doing chromagen A's when you are as a screening marker for neuroendocrine tumors, because in those patients with who are already on a PPI, you will have a false positive high chromagen A. In terms of imaging techniques, we've got our usual conventional radiographic techniques. We've also got lots of endoscopic tools that we can use, echocardiography from our cardiologists, and octreotide scans and gallium-68 scans. I'd like to actually go into a little bit more detail about that. So in terms of conventional imaging, we don't do small bowel series quite as often as we used to, but you can see here that that's a terminal ileal filling defect here, and this is commonly how these neuroendocrine tumors would be diagnosed. And then you can see here that you've got a mass here with sort of this stellate sort of splaying out of the bowel, and what you have here is you can see that this fibrotic reaction is really what causes that fixation of the bowel, and then what then leads to often abdominal symptoms such as obstructive symptoms, and this is also what you would see around the kidneys as well. In terms of how else we can see carcinoids and neuroendocrine tumors, in the pathologic specimens such as this of the small bowel, you can see that you have multifocal disease, 3 different small neuroendocrine tumors. I really do want to bring home the message here that especially in the small bowel, small size does not equal benign. So you can see here that there's a cross-section of one of our very small, probably sub-centimeter lesions in the small bowel, but look how it is already invading through the muscularis propria, which is this lesion here, which is this layer here. It's already going to the serosa. And so just because it's small, let's say under a centimeter, does not mean that it's something that you don't have to worry about. And then you can see here there are a variety of other endoscopic and EUS or endoscopic ultrasound images of neuroendocrine tumors. You can see sort of a very smooth, round lesion in the small bowel. You can see sort of a more pedunculated lesion here in the stomach, or also EUS images showing them in the rectum and pancreas. For many years, somatostatin receptor scintigraphy, otherwise known as octreotide scans, were really sort of the stalwart imaging technique that we used, functional imaging technique to stage our patients. This took advantage of the fact that you could radiolabel octreotide, which is a somatostatin analog, and then image them at 24 to 48 hours. This takes advantage of the fact that these neuroendocrine tumor cells will actually overexpress somatostatin receptors, and that the radiolabeled octreotide will then bind to the somatostatin receptors on the neuroendocrine tumor cells. Now, this was excellent in terms of its sensitivity. What I didn't realize until I became a specialist was that this could be a very inconvenient test, to say the least, for our patients. This is something that patients would have to return not just the first day, but the second day and possibly a third day. And so this is not really for somebody who's busy, otherwise working, and has other things to do besides do this test. It was inconvenient. They had to have a bowel prep, and so it was sort of like a combination of having a 3-day test with a colonoscopy, and just sounded like it's our patients were very dedicated, so they did it. We also had some issues there with false positives in the head of the pancreas and colon. So I actually just want to let you know, this is perhaps one of the take-home messages, that octreotide scans have now really been sort of ushered out, and we now have a new kit on the block, which is a gallium-68 PET-CT. Again, this will take advantage of the fact that we have a somatostatin analog, and it usually will be a DOTA peptide that's linked up to DOTA-TOC, DOTA-NOC, or DOTA-TATE. Again, these peptides will bind to the somatostatin receptor that's overexpressed, and what's great is that it's an increased sensitivity. It's only a 1-day test. Patients are finished in 90 minutes. And so in terms of the convenience factor, this is something that really can be compared to the old octreotide scans. So I just want to share with you some pictures of what this can look like. Here on the left, you can see the pictures you see some vague shadows here of metastatic lesions. You also can see the tumors in the liver. Now look at the 68 gallium test and how fabulous these images are. You can see detection of the lesions very clearly. You can also see detection of liver lesions and others as well. Now the one thing I will say, again, being a physician for these patients, is that you have to advise your patients when they see this, because let's say you've had an octreotide scan every year, and then you've now all of a sudden gone to the gallium-68. It can look like your disease exploded, that you're progressing, that things are going poorly, and so this requires constant advice and sort of really putting it into context that this is not a matter of the disease itself progressing, but much more that actually is just increased detection. We're just seeing far better than we ever did, and so this is incredibly important, that you have to not just use the test, but understand how to interpret it, and then and also in turn know how to advise your patients. Something that we get asked a lot is whether this is benign or malignant. To be quite truthful, sometimes it's not always easy to tell. I mean, certainly if you have metastatic disease, this is something that is very obvious if you have liver or other metastases. But sometimes people are in the middle and it's not very clear. So to confirm malignancy, we really will need local invasion, we'll need lymph node or distant metastases. And so that's this sort of trying to understand if these patients have malignant potential is something that we're always struggling to do. In terms of staging of small bowel neuroendocrine tumors, what was really quite amazing was that for many years there was really no widely accepted staging classification. So that's kind of the basics, right? When it comes to cancer, is that you generally stage patients. You have a specific number of tests that you do. You stage patients, and then you decide what the treatment is. And the fact that we didn't have the same language even within the field is sort of telling about a little bit how much in the dark ages I think we were for many years. As we all know, staging is helpful to classify patients. It's helpful in figuring out what's the best treatment and optimizing your outcomes. And the fact that only recently we've had this widely accepted staging rated system is something that is certainly is reflecting actually of a great shift in the field. And so just to be sure that we're on the same page, this is actually the most recent TNM, the T being for tumor, N for nodes, and M for metastasis. And not to go into any of the details here, but that generally your staging of small bowel neuroendocrine tumors will be dependent on size and depth of invasion when it comes to the tumor status. The lymph node status, it used to be just an N0, N1 designation, meaning that if you didn't have lymph nodes, you were an N0. If you did, you were N1. In the most recent American Joint Committee on Cancer staging system, they actually added an N2 designation. We often will see patients with mesenteric lymph nodes, and we've long thought that when they have mesenteric disease, that reflects a more extensive nodal involvement, and so it remains to be seen whether this is something that will actually play out in future renditions of the AJCC criteria. Similarly, in the M0, M1 metastatic designation, they are now having whether you are limited just to liver metastasis, extrahepatic liver metastasis, or whether you have liver and extrahepatic metastases. And so again, we'll have to see whether this is something that plays out in the staging criteria in the future. This is perhaps another important clinical pearl, is that I've already alluded to the fact you can see a wide array of biologic behavior. And so this is really one of our best biomarkers to be able to tell, do people have more indolent disease, do people have more aggressive disease? And so you can see here that our ability to assign a tumor grade depends on whether they have an elevated Ki-67 index, which is a proliferative index, or an elevated mitotic count. And you can see here that the higher the proliferative index, the higher the mitotic count, the more aggressive your tumors are. And so I would really urge all of you that if you're seeing patients with G1, perhaps those are patients that can be managed without a specialist, but I would certainly say that if you have G2 or G3 disease, that this is something that really, please do consider having a specialist see these patients. So as I've already spoken about, we have really a number of tools that are often coming from different disciplines, from different departments. We've got our systemic therapies where somatostatin analogs will play a major role. We've got peptide radioreceptor therapy. We've got targeted therapeutics. We've got local tumor control, and this can range from everything from, let's say, a limited surgical resection to all the way to a multivisceral transplant, which is something that we've started to work with some of the transplant surgeons here. Our interventional radiology colleagues will often do embolizations for those patients with metastatic disease in the liver. And then, as always, we have these various ways of controlling symptoms, somatostatin analogs, and some of these other modalities. I wanted to bring to your attention something that is sort of the NCCN guidelines here for metastatic disease, and something that really strikes me as very problematic is that depending on where you go, you can often be given different advice. And so one thing that our patients will often do is often seek multiple opinions because you will hear quite an array of different options. So just to give you a little bit of an idea of what that could be like. So for instance, for some patients with disease, they will perhaps be advised to resect their primary lesion in the small bowel and are also advised to undergo liver resection. So this, seems like a fair thing. You've got disease in your small bowel, you have your disease in your liver will resect both, we'll do a debulking surgery. And so that is certainly one option, and quite frankly, that's a very likely option if you come to Mount Sinai. Now, if you go, let's say, about 40 blocks towards Midtown at some of our colleagues, you'll actually get a very different set of recommendations. So if you are not really having that many symptoms, you'll actually probably be advised to observe your tumor. And so that's quite a large difference to be advised at one place in New York City that you can have a surgical or debulking surgery, and at another place advised to do nothing and just to survey. I mean, as a patient, I think that would be wildly confusing, and I think is something that we would really like to understand better, which patients are most appropriate for which types of treatments. Of course, octreotide and lanreotide, or somatostatin analogs, are frequently given first line, and particularly for those patients who have a symptomatic disease. In terms of medical therapy, I've already alluded to the fact that you can take advantage of the overexpression of somatostatin receptors, and so that mechanism accounts for a whole host of treatments, including the octreotide and lanreotide, and also our peptide radioreceptor therapies. But there are other pathways also that are affected with neuroendocrine tumors. So we often will use mTOR inhibitors to block that pathway, and so everolimus is frequently used for our patients with small bowel and pancreas, as well as actually some of the lung tumors. VEGF, tyrosine kinase inhibitors, are also used as often a second-line treatment. And so we're finding that some of these pathways may be affected in neuroendocrine tumor progression and in development. And so for that reason, we're finding that we're able to address some of these different pathways. Now, what I think has been incredibly exciting over the last decade is that, from like, let's say, institutional studies where we would describe our, let's say, experience collectively here at Mount Sinai. And we have a high volume, but I would say that depending on which neuroendocrine tumor you are talking about, you often would just talk about a few hundred cases. Now we're seeing these enormous, large, international, collaborative, randomized controlled trials where you now can look at different agents and look at specific scenarios, for instance, pancreatic neuroendocrine tumors, midgut neuroendocrine tumors, and actually start to do RCTs looking at specific agents. And so this has been a tremendous advance in our field in the last 10 years, and again, has been something that I think has really improved the number of outcomes and the number of options for our patients. I think somatostatin analogs, we've already spoken a little bit about. You can see here that there's a similarity in terms of how octreotide and lanreotide look to somatostatin, and that's why it's a somatostatin analog. You've got that disulfide bond, and then you've also got here these 4 amino acids that are essentially replicated on these analogs, and this is why this is such a very effective treatment for our patients. We also, do have not just, we actually have subcutaneous versions and long-acting, and again, approved for different reasons. Octreotide initially was much more approved for the treatment of flushing and diarrhea from the syndrome, whereas lanreotide was much more approved as an anti-cancer treatment, but quite frankly, we use these really interchangeably. I just wanted to share with you some of the best studies in this field so far. ProMed, I think, was the very first study where we actually had a placebo-controlled trial looking at octreotide versus placebo, and this is looking at progression-free survival. And as you can see, those patients on octreotide did much better on placebo, and so I think this perhaps can be an argument against some of those patients who are just being offered surveillance and no particular treatment, whether surgery or octreotide, and again, you're seeing this very nice separation of progression-free survival curves. These results were then extended to a publication in the New England Journal in the Clarinet study, where Marty Kaplan and colleagues looked at lanreotide versus placebo. And so you can see here that lanreotide had patients, and actually they didn't even reach the median progression-free survival as compared to these patients who had placebo, where clearly they didn't do quite as well as those patients. And so it is now, I think, thanks to these 2 studies, really first line that we all start with SSAs. Peptide receptor radionuclide therapy, I think, is a brand new treatment I want to let you know a little bit about. This is actually systemic administration of a targeted radiation. Again, this is myostatin receptor. It's got very high affinity of binding, specificity of binding, and it ensures that you're going to have specific delivery of radiation to the tumor. And so in the NETTER-1 study, which was published recently in the New England Journal, they had patients in this phase 3 study who had metastatic, advanced, progressive, myostatin receptor positive midgut tumors. And so this is a very heterogeneous group, and essentially randomized them to either a radiolabeled lutetium dotatate octreotate or to a high-dose 60 milligram octreotide LAO formulation. And you can see here again that you're not reaching your median PFS with the lutetium arm, and you can see here that you've got a great reduction in the hazards of progression and survival in terms of the Lutathera arm. The estimated median PFS here was 40 months, and so this is patients who I think has really revolutionized the way we treat patients, and now we're trying to understand how best to incorporate this new treatment into our existing treatment algorithms. I just wanted to spend one moment on symptom control because these patients are so very profoundly symptomatic. Again, the somatostatin analogs are going to really give you an excellent response rates for carcinoid syndrome. I just wanted to spend a moment here. I alluded a little bit here to serotonin synthesis and metabolism, and you can see here that there's a step where tryptophan is normally catalyzed into 5-hydroxytryptophan. And using now a tryptophan hydroxylase inhibitor, we actually can block this step such that you can't really form serotonin. And so what we now are experiencing is that our patients with severe diarrhea actually become constipated, which is something that we almost never see in our patients with carcinoid syndrome. And so we sort of have a new problem there with trying to modify so that we can get them into their sweet spot. So I've reviewed just very briefly, some of these many different treatments, and I think one of our challenges really is how best to integrate them. What goes first, what goes second? Do we combine treatments? What do we do? And the fact that the approach can be so heterogeneous depending on which medical center you go to, I find still very troubling and again very confusing for our patients. I mean, what is the role of surgery in metastatic disease? Is that something that plays a role? Should you go for embolization versus systemic treatment? What makes more sense? And then all the while, we're trying to also make sure that that we don't eliminate patients from future options. So in other words, you always want to balance that risk-benefit ratio so that, for instance, if you're giving PRRT, if you're going to perhaps suppress their bone marrow or give them renal insufficiency, that perhaps that's not a great option because it eliminates them from future options later on. And so understanding best how to sequence these treatments, do you do single agent, do you combine, how does that work, how does PRRT fit into the current treatment algorithm? I think all of these are really important questions that we're striving to understand. I wanted to share with you this, this figure that I think really illustrates what sort of living with carcinoid and neuroendocrine tumors can be like. In the beginning, let's say your primary tumor is starting to grow, and perhaps you've got some vague abdominal symptoms and you're diagnosed by somebody with irritable bowel syndrome. This makes perfect sense. You don't have anything specific that is sort of pointing anybody in the direction of carcinoid syndrome. But then over, let's say, years to decades, you develop metastases, maybe you start to develop flushing. I would say certainly that is about when people start to realize that this is perhaps not the right diagnosis. The correct diagnosis then of neuroendocrine tumors is made. They have diarrhea, and I would say, this is an older slide where death sort of occurred much faster, but I would say death is really occurring much later now because we have really terrific treatment modalities. So I think, just to summarize some of our ongoing clinical challenges, we certainly have challenges in diagnosis. It's a rare disease. There's nothing specific that points to neuroendocrine tumors and carcinoid until you get to very advanced metastatic disease. You've got a lot of physicians who are inexperienced with this, and very few who actually have a lot of experience. Patients are diagnosed late because they often are misdiagnosed with other more common conditions. And then we've also got these challenges in treatments. You've got these wide range in tumor biology, the quick progressors versus the stable disease patients. I have patients who have been diagnosed with metastatic disease who have survived 30 years and more. And so how do you know that, let's say, not after the 30 years have passed, but at the beginning when they've first been diagnosed, that you're actually going to do really well versus somebody else who might not survive the 30 years? Because patients often do well, it's, I think, increasingly important to really think about survivorship. This is not about conquering a cancer. In many ways, this is more like living with a chronic illness, living with prostate cancer, living with diabetes or asthma, something that really they're just having to live with on a day-to-day basis. You've got patients and physicians who have different approaches, and so oftentimes patients can go sort of shopping around to different physicians because they will get different recommendations on what to do. You've got these limitations in evidence regarding treatment, sequencing, and integration. And then finally, we've really got some limitations in some of our existing biomarkers. I think I had already alluded that our best biomarkers right now are a 24-hour urine test and chromagen, which are limited by PPIs. And so the fact that a lot of patients are on them, I think, is very troubling. So I just wanted to spend a few minutes talking about our work in neuroendocrine tumors. One thing that we've managed to leverage is actually the SEER registry. So as many of you know, this is a registry that accounts for approximately a quarter to a third of neuroendocrine tumors in the United States. As you can see here, they're represented by the shaded areas. And it's population-based in that a lot of the characteristics of this registry reflect the population at large of the U.S. And so you can see with respect to income, education, urban, foreign-born, that essentially this registry reflects the U.S. Population at large. And I think some of what makes the SEER registry so powerful for neuroendocrine tumors is that it addresses two limitations that we normally have in neuroendocrine tumor research. The first is that we have small numbers, right? Again, neuroendocrine tumors are very common apparently at Mount Sinai. We see more here than I ever thought I would ever see in my career. But yet, it's still on the order of hundreds of cases. To get to thousands of cases requires decades of a practice and decades of follow-up. And so right off the bat, the SEER registry has thousands of patients with neuroendocrine tumors, and so it manages now to give us some more sample size that we can look at differences between groups. Similarly, the other thing that has been troublesome and quite a challenge in doing neuroendocrine tumor research is that our patients have good outcomes. So if you're following things like overall survival, you're going to be waiting years and possibly decades for that outcome. And even if you look at more proximal events like progression-free survival, you're still going to be waiting a long time. Well, the SEER registry helps with that as well. You now can follow patients for 10, 20 years, and so this helps to give us some idea of what happens to a patient 20 years after they've been diagnosed. And so I just wanted to share with you some of the work that we've done in the last several years. One study that we did was looking at how the American Joint Committee on Cancer 7th edition did in predicting outcomes for patients with small intestinal neuroendocrine tumors. And so these were adults over age 18 who were pathologically confirmed. And for all of these patients, we assigned a tumor node metastasis status, and we also looked at disease-specific survival over 10 years. And what we found was that, first of all, as I said, you do have thousands of cases of neuroendocrine tumors in this registry, and so we had about 7,000 patients. That they tended to be, in their 60s. That they were largely white. That they were almost half were coming from the ileum, and that again, looking here at our patients with more advanced disease, that you're seeing a lot of patients who have metastatic disease and also regional disease with advanced lymph node metastases. And so this gave us an idea of what our population looked like. And then when we started to plot Kaplan-Meier curves and looked at disease-specific survivals, we saw that actually when you sort of did that according to the AJCC 7th edition staging classification, you actually had a lot of overlaps here. And so you can see here that stage 1 and 2A look like they overlap here, and also stage 3B and 2B they overlap here, and whereas 3A is down here, and obviously stage 4 is way here down the bottom. And so this was a little confusing into us, and it should be such a much better separation of curves. You shouldn't be seeing these overlaps, and we thought, well, this is not perhaps the ideal way to stage patients with these tumors. Maybe we should be thinking of other ways to do it. And so actually, we looked in a little more detail at the effect of the tumor status and the N status. And what you can see here is that when you are looking against patients who have a T1 N0 reference, that actually looking at T2 patients does not confer any additional hazards here of death. You can see that the hazard ratio is 1, that it crosses 1 here in the confidence interval, and so this is essentially the same as a T1 N0 group. Now, in contrast, T3 and T4, you can see that there are increased hazards of death here, not crossing 1 again, and sort of that actually sequentially increasing the more advanced the T stage was. And so that was a refreshing finding, but also good to know that T2 did not seem to be very different from T1. Now, when we look at the effect of nodal status in these patients, and we compare each group with lymph node involvement with N1 disease versus those with N0 disease, you can actually see that the patients with early T status, so in other words, T1 and T2, actually do have increased hazards of death here compared to their N0 counterparts, but that when you have more advanced disease, T3 and T4, that actually there was no increased hazards of death. And so this suggested to us that perhaps there was a differential effect of node status with respect to the tumor status, and then actually maybe you could revise the staging classification. And so what we did here was actually to combine different groups. We combined here T1 and T2 N0, then here the T1 and T2 N1 groups. To T3 and T4, no matter whether they had lymph nodes or not, appeared to be one group. And so you can see now that rather than having those overlaps that we had with that initial staging evaluation, that now you're having this beautiful separation of curves, and perhaps this is the right way to go when we're talking about staging our patients. Now, we took that study and essentially thought, well, if there are limitations with the existing TNM status, what else can we do for other neuroendocrine tumors? And so what we actually did was look at several candidate models, creating different staging models by reassigning T and N into different combinations. We followed a few rules that you can see here, essentially that only the tumor and nodal groups with overlapping survival could be combined to the same stage, and only that adjacent curves could be combined into a single stage. And looking at these different curves, you can see here that when you account for every combination, same thing, you're having T1 and T2 being very close, T3 and T4 being very close, but then nice separation here. And so what we actually did was we then did a number of different statistical tests to try to select the best staging criteria. We actually came up with 16 different models. I have to say that this work was done by Jake Martin, who was one of our medical students who spent a year of doing research with us, with me and Juan Witznowski. And so he had the best model here that would have a low AIC, which is a measure of prediction. The best model would also have a good C index, which is a measure of discrimination, and that there would be no overlap. And so let me just share with you what we found. So I'll share with you in just a second what our best model was, and this best model is this asterisk here, that essentially you've got a very low AIC, you've got a very high C index. In contrast, look at where the American Joint Committee on Cancer TNM staging classification that we all use is way over here. And so it shows that there really is perhaps a better prediction model that we can use, and there are better ways that we can use to stage these patients. So just to tell you what that actually was, this essentially started to combine different T1 N0 combinations. You can see here that stage 2 is comprised of T3 N0 plus T1, T2 N1, and then 3A combines T4 N0 and T3 N1. And so not to sort of really belabor the point, but you can see both in the derivation set and then also in the validation set that you can see that there's really nice separation of all curves according to overall stage. And so I think that some of our take-home points here that it's a very heterogeneous group of neoplasms. You've often got cancer that's moving in slow motion. You've got gallium-68 PET-CT, which is now the new gold standard. You're trying to, we really should be in every patient obtaining net tumor grade, but we still need to find better ways to group patients, better biomarkers to predict outcomes. And so I just wanted to share with you just this one slide. We've got a lot of stuff going on here at Mount Sinai. We have a prospective net registry that now has, I believe, over 600 patients with neuroendocrine tumors. These patients have all data fields, multiple things about their treatment and demographics included. We also have been collecting serum, plasma, and DNA, and this has allowed us to collaborate with translational and basic scientists. We've been doing a lot of health services research, looking at SEER Medicare, understanding perhaps some of the issues that come up with survivorship, with diabetes, by using these databases. We're also very interested in helping to develop biomarkers. We've been doing some collaborations with Rockefeller and Queen's University and looking at microRNAs, and these are hopefully studies that will lead to better biomarkers for our patients. Here at Sinai, we're also doing some digital image analysis and trying to work with our pathology colleagues. And then finally, trying to understand a little bit more about the epigenetic and immune microenvironment, and really understanding more about what drives these neuroendocrine tumors, and in particular, what drives tumors to progress. And then last but not least, because of the recruitment of Dr. Wolin, we now have many clinical trials here with novel agents. And so we're hoping to have a really terrific, wide-spanning research program that can help to advance the care for our patients. I just wanted to briefly acknowledge many of the mentors and collaborators and research team members who none of this could really have been done without. I think a special shout out to Juan Wisniewski, who has been just a fabulous mentor, and without whom none of this would have really occurred. Steve Itzkowitz, I think, recruited me initially here 15 years ago, and I wasn't interested in neuroendocrine tumors then, but thanks to his introduction to Dick Warner, I became very interested in neuroendocrine tumors, and it's been really a terrific ride since. And then again, we have many collaborators and research members whose names are listed here. Thanks very much.
I think we have time for one or two questions. Yes.
Thank you very much. Two-part quick comment. There are several people in your audience who first learned this disease 60 years ago from Dr. Warner. So it's amazing to be sitting and listening to the advances. The other is a question. Do you consider this disease to be likely hereditary or to be acquired? And along those lines, have you or your colleagues ever studied identical twins with this disease?
That's a great question. So actually, for your first question, so there are a few forms that are actually hereditary. The most common that I think we all know about is the MEN1 syndrome, which encompasses hyperparathyroidism, pituitary lesions, and also pancreatic neuroendocrine tumors. There actually, in recent years, has been a description of a familial small intestinal carcinoid variant, which is extraordinarily rare. You're now taking a rare disease and now taking, now we're talking about maybe 100 or 200 people in the world. That research is actually being headed up by Steve Wank at the NIH, and he's actually got some very interesting family clusters that he's following. I forget your second question. What was your second question? Twins. Oh, yes. So actually, we have not studied twins because, as you can imagine, it doesn't happen very often. But Dick Warner actually did have one twin, set of twins, and essentially what ended up happening was that one of the twins had metastatic disease, the other did not, and because of that, the twin who did not have metastatic disease was actually able to donate a liver to the other for a liver transplant, and that actually helped to control her disease.
Did they both have syndrome?
No, only one had disease, the other one did not.
I think we're actually over on time. If you'd like to come up and ask questions, thank you very much.